hope everyone's doing well, meeting after a long time. So, the topic for today's class is going to be on imaging of aortic diseases. This is something which is a very, very specific topic, usually not in the domain of general radiologists, but as residents, there are certain things that you should be knowing that, if you are posted in the emergency and you end up having a CT case of any of the acute aortic emergencies, you shouldn't be dumbfounded. You don't need to know at resident level what are the pre-operative measurements and all of those things about the interventions, but at least we need to know about the acute aortic emergencies, and that's what I'll be focusing on, that what a resident should know. Apart from that, all of the specific things about the interventional aspect, I'm sure Akhil will handle it much better. So the domain of today's lecture is going to be mainly the imaging, and what do we need to report in a case of dissection in an aneurysm, and what are the clinically relevant things, right? So that's what I'm going to be discussing, and of course the protocol and a few things about endo leaks and stuff that we should have an idea about as a resident. So I hope everybody is doing well. On a side note, I'll talk about it towards the end also. We have a case discussion coming up on Monday, day after tomorrow. So if anybody wants to volunteer, you can just message on the group. If you are new and you don't have Telegram link, let me just send that in the chat. So you can join the Telegram group. Just beware of any scammers. Please don't send money to anybody, no matter how authentic the profile seems. Just don't be scammed. But if you want to volunteer for the case discussion, you can just send a message, and we'll be discussing a few long cases and short cases. Okay. Lung cancer, imaging and staging of lung cancer. We can have that soon. Basically, I thought I covered pulmonary nodules, so I didn't want to go into the details of CA lung, but I can cover. Doppler is coming up. So the plan, I was just planning out the classes for May as well. So May almost entirely is planned. What we're gonna do is head and neck first, okay, and then we'll talk about Doppler, because a lot of you have been requesting for Doppler, and then there are few high topics like leukodystrophies and skeletal dysplasias from peds radio that I want to do. Okay, so that is what I have lined up. I'll share the schedule with you. Just planning it before the class. Okay, so any other requests that you have, you can just let me know, because by mid-May we cover almost all of the important topics of all of the systems, and then we can do the requests. CVS, see, personally, cardio rad is something that I don't have very good exposure to. At AIMS, there was a different cardio rad branch. That's why, I don't want you to teach that, because personally, I'm not very good at it, and I have not reported many cases myself. Even aortic diseases, we never reported, so I'm not good at it. So I don't want to teach you something which I am not an expert in. But we have Dr. Ashish, who's gonna start tomorrow itself, and he is doing cardio rad. He practices cardio rad. So I've requested him to start with the basics of CT angiography, coronary angiography. And I think it will be better if you learn it from somebody who's been doing it, and I can restrict more to exam topics and stuff that is more important to us for day-to-day reporting. Yeah. Barium again. Barium also, I hate barium, but I can try. I can try taking barium for sure. Dr. Rishabh actually is also having his thesis, so he is a bit occupied with that, but coming months he will be much more free, so he can take more lectures. Okay, yeah, I can ask Nikita ma'am to do barium. She tends to like stuff that everybody hates, so probably she might like, and then I can ask her to take. Okay, yeah, but because you guys requested so much for MRI physics, that's what she's doing, so now you can't be like, no ma'am, please forget our old request, now do new. So now you can't be like that. You only asked for MRI physics, right? So that's why she's covering that in detail. So let her do that. Let her finish physics, and I'll try and do barium. And if she can take up barium, I'll do that. Apart from that, if you have any specific topic requests, which are important for exam, not just that ma'am hame ye nahi pasand, but important for exam, we'll do that. Okay. So yeah, chalo. Shall we start off with aortic diseases? All right, so let's start. So let's talk about the normal congenital heart diseases. As I said, all cardio-rad topics, we'll ask Dr. Ashish to cover because I don't have that much exposure to cardio rad. At AIMS, everything used to go to cardio rad. So I have not reported a single case as a radiology resident of a congenital heart disease. So it's better that you learn it from somebody who's doing it day in and day out. Yeah. I teach well, yes, but it's better that you learn some things from expert. There are so many things in radiology to learn and to teach, right? So I'll rather do the others, which I am good at. No? Isn't that better? Yeah. All right. Okay. So thank you. Yeah. From now on, loads of classes. Again, the next I'm relatively free, so loads of classes planned ahead. We are doing head and head and neck is again something that lot of you find, weakness in, which is temporal bone, paranasal sinus, larynx, head and neck spaces. So that's what we are going to be doing, all tough topics next month. Yeah. So that's what is the plan. Okay. All right. So let's start off with some normal anatomy of the aorta. So this is, as you know, the ascending aorta. Yeah, ascending aorta, arch, and descending aorta, but that's very, very primitive. So now let's go into the specifics. Can you tell me what is 1 or 1A, 1B, 1C? Tell me. Q bank. You mean the solved DNB papers? And again, that is also something which I have now actually asked better and more senior people to start making the papers, because there were some quality issues earlier. So we will rectify that, and I shall be, getting it uploaded pretty quickly. So foreseeably in the next 2 weeks, all papers should be completed. Okay. So you can go through them before your June exam. All right. Okay. So 1A, 1B, 1C. Let's do the anatomy. So what is 1A? 1A is the level of the aortic valve. All right. So just above the aortic valve, what do we have? What should be 1B then? So that is what you guys were saying, sinus of Valsalva, right? So that is just above the aortic valve. We will have the sinus of Valsalva. How many sinuses do we have? Yeah, remember anatomy, little bit anatomy. So we have one anterior cusp and two posterior cusps, right? So usually what arises from the anterior cusp is the right coronary artery. What arises from the left posterior cusp is the left coronary artery. And usually this is the non-coronary cusp, which is the right posterior one, right? So this, as you all remember, is our sinus of Valsalva level. At 1C, do you see a bend here? So wherever you see this bend, this is very, very important hallmark that everything is normal here. So this is called as the junction between the sinus and the ascending aorta. Very good. So this is the sinotubular junction. Okay, so this is the sinotubular junction here. That is 1C. Now we go on to 2, which is basically the ascending aorta. So anything above the sinotubular junction, basically you have this bulge and then you have this equal, consistent part. This is what we call as the ascending aorta. Then we have the arch. Within the arch, we have 3A and 3B. So basically 3A is the proximal arch. Up till the origin of the left coronary artery is the proximal arch. Up till the origin of the left subclavian is the distal arch. And then this is the part we call as isthmus, right? So these are the 3 parts of the aortic arch. So proximal arch, distal arch, and the level of the isthmus of the arch. So this is how we divide the aortic arch into 3 parts. And then 5 is obviously the descending thoracic aorta. Okay, so this is what is the anatomy. On a CT coronal view or coronal oblique view, what we see here is the outflow tract, and then you see this, right? So this is the level of the sinotubular junction, and then the consistent part becomes the ascending aorta. All right, so this entire bulge here can also be, one entire part can be called as the aortic root. Can you name a disease in which we see aortic root being involved primarily or most commonly? Which disease will you see aortic root abnormalities? Very nice. Marfan's, right? So Marfan syndrome, you will have aortic root dilatation, which is something which is very, very common, and any other connective tissue disorder like Ehlers-Danlos loss as well. Okay, so this is the part we got to be careful about. All right. So now taking into account the diameter. So the numbers that you want to remember is 2, 3, and 4, right? So the normal maximum aortic diameter, which is considered to be normal, is, remember the rule of 2, 3, 4. Ascending aorta, 4 centimeter, descending thoracic, 3 centimeter, abdominal aorta, 2 centimeter. So remember 2, 3, 4, like that. And aneurysm is anything which is 1.5x dilatation of the maximum normal diameter. So having said that, abdominal aortic aneurysm will be any aorta which is more than 3 centimeter dilated. Descending thoracic will be anything which is 4.5 centimeters or more dilated. Okay, so these are the two where we have consensus. For ascending aorta, no consensus as to what diameter do we call dilated, but basically anything more than 4 centimeter is considered to be dilated in ascending. But for descending and abdominal, we have clear-cut definitions which are accepted universally, that 1.5x, which translates to 4.5, or basically 3 centimeters. So don't remember exact values, just remember the multiple and you will be good to go. So 2, 3, 4, 1.5x. These are the numbers as far as normal aorta is concerned. When we talk about measuring, so descending aorta, you can measure in the axial plane. Descending aorta, the diameter is measured in the axial plane, but ascending aorta as well as aortic root are all measurements that are recommended in the coronal plane. So here you want to measure in the coronal plane, which is going to be perpendicular to the lumen, whereas descending aorta distal to the isthmus, we measure in the axial. So Suhara, anything which is not 1.5x. So between 1x to 1.5x is what we call as ectasia, right? So anything which is in between, which is less than 1.5x but more than the normal, is what we call as ectasia, right? Having said that, aneurysm will be focal, ectasia has to be fusiform, and ectasia cannot be saccular, whereas an aneurysm can be fusiform and saccular, but ectasia will always be fusiform. So those are the two things we need to keep in mind. All right. So voice break in between? Is it?